Hello. Acute laryngotracheal bronchitis, which means infection involving the larynx, which is a voice box, involving the trachea, the windpipe, and the bronchus. So the bronchus which extends to both the lungs. Now, so the infection involves the whole system starting from the larynx to the bronchus, the whole airway. So first let me show you a picture of this airway, then I'll proceed with the symptoms, signs, what are the necessary investigations and the treatment part. This is the larynx, trachea, bronchus. See, the whole system, it's little expandable except for this area, the subglottic area, because in this area the cricoid cartilage, it forms a complete ring. Not only that, the inside part of the cricoid cartilage, it is the mucosa there, or the lining there is very delicate. So when there is any inflammation involving the whole system, the whole burden will be mainly in the subglottic area, because this area is not able to expand to let in more air. So the definition will be acute laryngotracheal bronchitis means it is inflammation involving the large portion of the tracheal tract, mainly with a maximum effect on the subglottic area. Now this is a picture where you can see there is no edema or swelling, the airway movement is normal, it's patent. But the second one, here you can see the whole subglottic area is edematous. Actually the whole system should be edematous, it will be edematous. More effect on the subglottic area and the trachea, mainly in subglottic area, so it hampers the normal flow of air. It's usually seen in children less than 7 years of age, and it is due to a particular virus called parainfluenza type 1 virus, and which is the most common type. Now the complaints. To start with, the patient will start with nasal discharge, nasal block, mild fever, which progresses to cough. And the cough is a particular type of cough. That is, you must have heard of an animal called seal. When it makes a sound, it's a particular type of sound. It is almost similar to that. And along with a severe cough, troubling cough, you have change of voice, and it will progress to breathing difficulty. So on examination, we'll find the child is febrile, and the pulse rate is more than 100, 110, and the respiratory rate is also more, and the child will be experiencing breathing difficulty, and we call it stridor. So we need the following investigation to start with: complete blood count and CRP, which shows the levels will be high, which indicates that there is some infection in some part of the body, and we have to confirm which part of the body. So see this X-ray. I have put a normal X-ray, and here you can see the air column, which is almost of the same width. But here, see, if you see the air column here is broad enough, and slowly it becomes tapered and like a pencil sharpened. It's called an apple core appearance or staple sign. So it means there is a significant narrowing in this part. And as soon as the patient will start treatment and the investigation, already he'll be on pulse oximetry, and we have to know the pulse and oxygen level, how much we have to monitor the oxygen level also. We'll go ahead and do a flexible laryngoscopy. See, flexible laryngoscopy is not for diagnosis of this part, of this condition. We have to rule out other conditions too. So the flexible laryngoscope, which is usually done in the ICU, because the child is observed in the ICU, and if you see this video, the flexible laryngoscopy, it already reaches the posterior part of the nose, and this is the starting part of the larynx. So the infection has started here, and the whole upper part of the larynx is edematous. Now I'll show you the subglottic area also. So here, if you see the vocal cord movements and subglottic area, there is narrowing, and the whole area is congested also, red in color. So as mentioned earlier, treatment will be in intensive care unit because the child can develop respiratory failure or metabolic acidosis. That's why. So we'll give the oxygen, a high flow of oxygen. It will be continuous. And suppose we have a facility. Suppose the hospital has got a facility of having heliox. So we'll replace that with oxygen. And it is mainly indicated only in those cases of severe stridor. Otherwise, it can be well managed with oxygen. So first we'll decide whether it's a mild case or a severe case. If it is a mild case, oxygen inhalation and along with it, a shot of steroid will be more than enough and the child can be discharged the same day. If suppose it's severe case, after the necessary investigations and we'll start with first shot of steroid and along with that, we need nebulization. Nebulization to start with, it will be adrenaline and followed by budesonide. And if necessary, if there is a lung congestion also, we will start Ventoline 2. See, in this chart I have given details and how much dose to be given. But please bear in mind, all this treatment should not be done at home. You have to rush to the hospital. The doctor will decide whether it is mild or moderate or severe, and he will give the medicine accordingly. Doesn't mean that what I have shown doesn't mean that all the nebulization need to be given. They have to decide the dose, what frequency it has to be given, what are the side effects, monitor the side effects, and so on. So please do not take self-treatment. Let the doctor do the proper treatment in the proper manner. So usually in severe croup with these medications, it will settle down within a day or two, and the patient will be shifted to the normal room, shifted out of the ICU. And if suppose the child does not improve by second or third day, we may add up antibiotic, presuming that there is superadded bacterial infection also. Usually antibiotic is not necessary. By second day or third day, when the child is normal, afebrile, and the total count of CRP has come down and breathing normally, it is time to discharge a child. So that's how we manage a case of acute laryngotracheal bronchitis. Thank you so much.